Hello, it's Polly again. Okay, we're on session 6, which is about identifying early in pregnancy and reaching the most vulnerable. This is a short presentation to talk about the rationale behind reaching and prioritising the most vulnerable families. Many public health models in the higher income countries have already adopted a more social determinant sensitive public health model. So an example of this is in the United Kingdom. The community health visitor model is considered to be a responsive service strategy. So the community health visitors are trained on the identification of risk and vulnerability factors, and although all women having children will receive a visit from their health visitor at some point, there are tailored visiting schedules which are conducted according to the level of vulnerability and need. And primarily the community health visitor's role is to link the family in to any additional needs and resources that they might have. Community midwifery services often function in the same way. So routine antenatal services will identify and refer people with particular vulnerabilities. Then community midwifery teams are targeting the most vulnerable people in their households. So we have home-based antenatal care, if you like, conducted by community midwifery. So these and other programs, such as the Healthy Child Programme, is an evidence-based programme where you have a combination of universal and targeted assessments and interventions to meet the identified need. And this is always done using a cross-sectoral approach, so particularly in partnership with health and social care. So in the context of Lesotho, we're taking an integrated cross-sectoral approach that embraces things like education, agriculture and social care. Why do we do this? Well, let's think about what the real-life contexts are. Tell me, looking at this picture, which one of these women experienced significant barriers to a healthy pregnancy? The fact is, it's impossible to tell. Individual women may have medical risks. However, those medical risks can be severely exacerbated by social vulnerability factors such as poverty. When it comes to psychosocial vulnerability, all women have a need for psychosocial support at some point in time. And there's no particular determinant that tells us which women are most vulnerable to maternal mental health and social support. So we always need to triangulate our analysis of vulnerability in the different dimensions of vulnerabilities that exist on the emotional, physical and social trajectories. So let's think about what these vulnerabilities are. Take a moment to brainstorm in your groups what you think are the emotional, physical and social vulnerabilities. Pause the recording here. Examples of physical vulnerabilities for a pregnant woman include chronic health problems such as asthma, diabetes and other chronic disorders. But there are also pregnancy-related conditions and obstetric risks. Some women, such as adolescents and HIV-positive mothers, will have physical vulnerabilities throughout their pregnancy, and also the way that a woman is able to care for herself in terms of nutrition and self-care are very important physical determinants of vulnerability. In the emotional dimension, as we mentioned before, all women from all walks of life can be affected by maternal mental health. But also there's the level of rest and work-life balance that is achievable for that individual. A level of anxiety and stress imposed by social and other factors may also influence her emotional vulnerability in pregnancy. Underlying all of this is the social dimension of vulnerability, so that could include her access to social support structures, community-based help, financial concerns, extreme poverty, single mothers, social isolation and exclusion. And of course there are psychosocial issues that may be occurring such as violence in the home, domestic conflict and drug and alcohol use. So how would we support a mother in these three domains? Well, the emotional dimension of vulnerability is addressed through psychological first aid. In terms of the physical dimensions, that's addressed in the modules supportive care for the most vulnerable cases. That's where we require the village health workers to tailor a responsive care strategy for individuals with specific health needs. And in terms of the social response, well, we need to be assessing the vulnerability level of each household during our household assessment, looking at the key resources for health that they have, and address that through priority home targeting. So what I mean by that is spending more time with families with bigger needs. So in your modules, this session is session 6, so please turn to the appropriate page for the following activity. So I want you to think about an iceberg. If you remember in the film Titanic, the boat was sunk by hitting an iceberg. The thing about an iceberg is that only about 10% of it is seen above the water, and most of the iceberg is not visible. This is very similar to community health programs. So when you want to conduct a community health program in your communities, who are the families that you find are easy to reach? And which are the families that are typically left out? Pause the recording now and brainstorm in your groups which families are easier and harder to reach. The easy to reach people include frequent health service users, people who frequently attend community groups. Those are the people who have access to transport, so they may tend to be wealthier or located in more convenient locations. They also tend to be literate. Literate people are easier to reach because they have greater access to media. They will often be people who have family support or have free time. But the harder to reach people live further away and have transport and access barriers, possibly also experiencing financial barriers as well. Illiterate people are particularly hard to reach and may have language barriers that prevent them from accessing information through media and local radio. These people often don't hear about events for community health, or they don't have the family support and time to attend them. So who are we going to be accessing easily? Mothers with free time, typically married women who are active, who are healthy, and who live in convenient places. The mothers we're not accessing tend to include adolescent mothers who rarely participate in community events unless they are targeted for adolescent mothers, single women who are working and don't have financial support at home, women who have many children, who have low family support, women who are disabled or sick, or potentially who are caring for sick people at home, HIV positive people, and very poor. So what are the health practices of these different groups? Let's brainstorm now in our groups, pause the recording and think about what the health practices are of the easy to reach group and the hard to reach group. So the easy to reach group will tend to have better health practices. They have more access to health facilities and services, and they may also have better nutrition and hygiene in the home, whereas the hard to reach group seeks services less frequently, especially when it comes to urgent care. They experience barriers to access, and in the household they're more likely to have poor hygiene and nutrition practices. So if we want to change behaviour in our population, we really need to focus all of our time and energy on those people with poor health practices. So where should a community... So maternal and child death is not clustered evenly across the population. In fact, most studies show that it's a small percentage of people that experience most of the deaths. When we think about the distribution of behaviour change practices, we define people according to a bell curve of the rate at which they adopt a health practice or behaviour. Those people who hear the message once and adopt it quickly are the very early adopters, and the other side, the late majority and laggards, are the people who adopt health behaviours much, much later. So in terms of child mortality, early adopters of positive health practices are much less likely to experience a child death, whereas the laggards are the people with the highest rates of child mortality. So again, we want to be focusing our attention on people who don't adopt health behaviours quickly. This is an exercise that is in your session 6. So I want you to turn to that session and have a look. This exercise is called What Are the Odds? And it's designed to help village health workers think through what the difference is between these different types of groups of people. So the first case is a woman with less than 18 months of birth spacing between her youngest children. We've actually put the odds ratio, but we've translated this into the same, more likely, very much more likely. In the case of a woman with less than 18 months between her youngest children, she has 36% higher odds of child mortality for those 2 children. So this is more likely. A woman with high parity or a household with 4 or more children under 5 years. Much more likely. This is 131% higher odds of child death. Maternal orphan or absent mother. 1,500% higher odds. This is very much more likely. So we already know that anyone who's orphaned or their mother, biological mother, is away from them during their infancy, we really need to be targeting those children very, very carefully. An adolescent mother. This is more likely, so up to 40% higher odds, although this is highly variable depending on the amount of support the adolescent mother has. Single parent, so this is typically a child with a mother but no father. 100% higher odds. Okay, so the effect of a father is to double the probability of a child surviving to 5 years old. So we can see that fathers are really, really important. Mothers, however, still have a higher odds ratio of improving the survival rates of the child. And largely this is because of the health interventions such as breastfeeding that have a really big impact on child survival. So we categorise people in terms of behaviour change as doers or non-doers. So doers being those who quickly adopt a behaviour and non-doers who rarely do a behaviour. So when we do our barriers analysis, we group people as doers, non-doers. And the 2 questions that we typically use to do the analysis, for people who do a particular behaviour, we investigate what makes it easier for them to access that practice. And also we can ask them questions about their preferred service providers and why they do that. For the slow or non-care seekers or non-doers, we ask them what makes it difficult, what are the barriers for them to access, and what service providers do they use. So how do we ensure that village health workers identify and support homes? Well, the first function that they have is a signposting one. So this is for making links, and that could be to health or social services, but it could also be to other community-based programs. So we assess the needs in terms of all of these different issues: ICCN, PMTCT, DOT, TB treatment, CMAM, mental health services, gender-based violence support, social services, child protection, and also those income generation and community groups and projects that people need. And the village health worker has this principal role of identifying the needs and making links to them. Secondly, we identify their needs through dialogue-based counselling. So this involves having good communication skills, applying dialogue to do a barriers analysis, listen and link, which we'll learn about later from mental health. This is about listening to their needs and linking them to the support that they need. However, we always take an empowerment approach, so the family should be monitoring their own progress. And we also need to spend the most of our time with people with more needs. Lastly, in a mental health approach, we apply psychosocial support. The supportive care for the most vulnerable families are included for each cohort from pregnancy, newborn care to children. So there are particular modules or sessions which talk about supportive care for the most vulnerable pregnancies. That's adolescents, HIV, existing conditions, single or unsupported mothers, or mothers experiencing domestic violence, gender-based violence, or psychosocial problems. Supportive care for the most vulnerable mothers includes those who've had complicated births or caesareans, adolescent mothers, mothers living with gender-based violence or mental health, and postpartum depression. Most vulnerable newborns include HIV exposed, small babies, and those with congenital malformations. Most vulnerable children includes HIV positive, orphans or maternal orphans, any child who is not breastfed who's had a current or prior severe malnutrition case. And we especially need to include extra early child development support for those cases, especially in neglect, abuse, low birth weight babies, HIV positive babies, and malnourished children who experience the biggest barriers to mental, cognitive, and physical development.